Agnieszka, you make a clear distinction between tractional and non-tractional diabetic macular edema. What is your leitmotiv, please?
How do I switch? Is it switch on? Okay. Thank you very much. And actually, the point is that during my talk, I would like to emphasize that there is no much of a difference between tractional and non-tractional diabetic macular edema from the perspective of pathology. Talking about treatment, I think it's very important to know the pathology that we are dealing with, because only by understanding what's going on in the eye, we are able to give the proper treatment. So if we ask somebody what is the main cause of diabetic macular edema and diabetic retinopathy, everybody would say that this is vessel leakage and non-perfusion, and this is quite obvious. And everybody knows that, but this gives just two-dimensional understanding of diabetic retinopathy. To dig to dig a little bit further, we need to look at the eye with retinopathy as the three-dimensional structure, and we need to understand that changes occur in all elements. Changes occur in vitreous, in ILM, and in retina. This is not just the vasculature that is sick during the retinopathy. Why traction and no traction question is so important? Because for some reason in literature, when you start finding the way of treatment of diabetic macular edema, you will find publications saying that if traction is present, you are allowed to perform vitrectomy. But when you do not have any traction, vitrectomy is kind of even forbidden, and only injection are the proper treatment. So my question would be, what is traction? Is traction a real force that is between tissues, or is traction something that can be seen on examination? Because if traction is something that we see on examination, this is closely connected to the resolution of the machine that we are using, of course. So 10 years ago, we would never say that the picture on the right is tractional, because we did not have any tools to detect that. And now with new machine, we are able to do that. We have another tool to have a closer look to the diabetic macular edema. And here I would like to show you the movie from the surgery done in diabetic macular edema without any traction. You can see like it's very difficult to obtain the posterior vitreous detachment, and I need to fight with the vitreous, and I'm pulling it very hardly. I used a little bit of too much of the blue dye, but you can see that this dye is pulling in front of the retina. So my question would be, is it tractional or is it not tractional in this case? And definitely in this case, there was no preretinal tissue at all. Another observation that was made during the vitrectomy was retinal perfusion. And this is the same eye, and on the left side, you have the moment that there is no PVD performed yet, and on the right side, this is the same eye after PVD is performed, and you can observe how vessels behave differently. They pulsate when there is no PVD, and they do not pulsate. They behave, the flow is regular when the PVD is done. That means that a touched vitreous does something to the vasculature. So the question is, what is the pathology of diabetic macular edema and retinopathy in general? And I would like to start not from the vasculature, which is obvious and understood. I would like to start from the other part of the eye, which is vitreous. We know from diabetic study that hyperglycemia induces lots of changes within the body. And you know that changes in arteries are very common, and diabetic patients have strokes, heart attacks, and so on and so on. And they have this because hyperglycemia induce non-enzymatic glycation and cross-linking of collagen fibers. And these collagen fibers are exactly the same fibers like in the vitreous. So the vitreous in diabetic patient is changed. It got cross-linking, and the cross-linking changed the mechanical property of the vitreous. And the vitreous is no more like a normal vitreous, it's more like a glue, that is something inside the eye that's changed the property of the inside of the eye. Because the structure is changed, very often hyaluronic acid gets separate from the rest of the collagen fibers, and we have some sort of pocket that is formatted more to the back of the eye. That causes ascites to occur very often. So there is no such a thing, I guess, as posterior vitreous detachment in diabetic patients. There is more ascites, and even if we create PVD during the vitrectomy, we can kind of unroof the top of the cyst, but on the ILM we still have some collagen left. Why it is important? It might be important because of the traction that could be put to those structures. ILM is also changed in diabetic patients, and on the photography in the top you can see the ILM peeled in macular hole case. In the bottom picture you can see the ILM peeled in diabetic patients, and the ILM is thicker in diabetic patients, that is for sure. And what can we see? They are cells, and those cells are mainly on fibrotic origin, fibroblasts, okay. Gandalf performed a very interesting study when he, during vitrectomy, was checking the findings on ILM and in the vitreous. So he came to the conclusion that ascites is the hallmark of changes in diabetic patients, and they are cells on ILM from the vitreal side. And he came to the conclusion that even when no obvious traction is present within the eye, the vitrectomy can help with resolution of diabetic macular edema. And this is the result of one of his patients, and you can see on the top picture that there is a edema. On the bottom picture, there's no edema in macular region after vitrectomy, and those two pictures in the middle, they show cells that they were located on the ILM. So coming back to my scheme, in diabetic patients we have changed vitreous that is much gluish. We might have a pocket of liquefied vitreous somewhere in the middle. We can have thick ILM, and ILM, we need to remember that ILM serves as the scaffold for cells proliferation, and in the same time ILM is the barrier of water flow. And in regular conditions, here in the apex of Muller cells, there is aquaporin situated, and this aquaporin helps water come from the retina to the vitreous. When the ILM is very thick, the flow of the water from the retina to the vitreous is very changed. During the time those changes progress, we can see more and more cells, and those cells are, as I said, fibrocyte. They are also astrocyte and macrophages. They secrete VEGF. They can secrete inflammatory particles which are trapped within the vitreous and stay in front of the retina, and they may exaggerate the edematous changes within the retina. If this process is not stopped, the changes are more and more profound, and I do believe that at some point they start being visible because they are so profound and so big that this allows morphological changes to occur, not only on cellular level, but also at the more visible level. And I think this is the moment we start calling this tractional, because we can see the changes within the eye. Very important is the behavior of Muller cells, because they are actually responsible for keeping retina together, say it simply. They serve together with photoreceptors and the vasculature bed. They are some kind of retinal neurovascular units, and they prevent photoreceptor from dying. They have forces to repair retina, but during the time when diabetes and diabetic macular edema is present within the eye, those forces of Muller cells are getting weaker and weaker and weaker. They are not able to restore retina anymore, and that's why the edema is more and more profound and persists.